Hi everyone, Dr. Mike here. When it comes to pain associated with the oral cavity, the face, and various aspects of the head, all roads lead to Rome. And Rome in this case is the trigeminal nerve. Now the trigeminal nerve is one of those 12 pairs of cranial nerves. In actual fact, it's the fifth cranial nerve and it's the largest cranial nerve. It's also a mixed nerve, which means it sends sensory information about what's happening in the environment, but also sends out motor information to tell various muscles to contract. Now there's actually four divisions of the trigeminal nerve, three sensory divisions and one motor division. So let's take a look at pain associated with the trigeminal nerve, which means we're focusing on the sensory divisions, but we'll also talk a little bit about that motor division. So what we've got here is an image of the face, and we're going to take a look at what type of sensory information does the trigeminal nerve allow for us to experience. So firstly, the three sensory divisions include that of the ophthalmic division, also known as V1, the maxillary division, also known as V2, and the mandibular division, also known as V3. And you can see here, I've sort of separated out how these various different nerves allow for us to feel or experience certain types of sensations. So the ophthalmic division allows for us to experience sensation associated with the skin of the upper aspect of the face, so the bridge of the nose, the cornea of the eyes, and the forehead, for example. But it also sends sensation associated with the dura mater and the associated vascular supply. So think about this. The dura mater is one of the three meningeal layers of the brain. You've got the pia mater, the soft tissue that's most adherent to the brain, then the arachnoid mater, then the dura mater, which is the thickest layer. Now, the vascular supply associated with these areas innervated by the ophthalmic division. Now this is important because when it comes to headaches and migraines, we know that in many cases they're associated with constriction, dilation of these blood vessels, which tells us that many headaches and migraines are associated with the ophthalmic division of the trigeminal nerve. Then when we take a look at the maxillary division, allows for sensation of the middle aspect of the face. So this includes the upper lip, the nose, the nasal cavity, the oral cavity, including that of the upper teeth and upper gums. And when it comes to the mandibular division, allows for sensation of the lower lip, the lower teeth, lower gums, and also that of the temple. So we've got all this sensory information coming in. Now, what type of sensory information are we picking up? Well, it's picking up three major types, right? It's picking up information about touch, information about proprioception, and information about nociception and temperature. So touch includes that of two-point discrimination and vibration and pressure. Proprioception tells us about where our body is in its own space. What does that mean? So think about it. If I close my eyes, I can take my finger and touch my nose. I don't need to see where my finger is. I don't need to see where my nose is, but I can do it because I know where my hand is in its own space and where my nose is. And that's because there's various receptors located in our muscles and our joints, for example, that tells us how bent a joint is and things like that to allow for us to know where it is in its own space. So that's proprioception. Nociception is picking up noxious stimuli that may potentially damage tissue, and temperature, I think, is self-explanatory. So this is the type of sensory information we're picking up from these sensory divisions of the trigeminal nerve. Now, I told you it's the largest nerve. It also has a huge amount of fibers associated with each of these divisions. So these fibers, for example, include the fact that the ophthalmic division has 26,000 fibers associated with it. The maxillary division has 50,000 fibers, and the mandibular division has 78,000 fibers. And this is because our face and its various associated areas is very dense with neurons. So all of these sensory divisions, they're coalescing together at an area that we call the trigeminal ganglion. Now, the way that these neurons come in, remember, we're going from innervating aspects of the face, the oral cavity, the nasal cavity, the head, and so forth. It needs to go now to the central nervous system, which means it needs to move through aspects of the skull. So what are these various aspects that these three divisions are moving through? Well, let's take a look. When it comes to the ophthalmic division, it moves through an area called the superior orbital fissure of the skull. When it comes to that of the maxillary division, it's moving through the foramen rotundum. And when it comes to the mandibular division, it's moving through the foramen ovale or foramen ovale. So as they move through, they coalesce, come together here at what's called the trigeminal ganglion. And remember the definition of a ganglion. This is where the cell bodies of neurons reside outside of the central nervous system. So here's the central nervous system, brain, brainstem. So cell bodies outside of here reside in a ganglion. If you have cell bodies residing inside the central nervous system, they're called nuclei. That's the difference. Ganglion, cell bodies outside central nervous system, nuclei, cell bodies inside the central nervous system. So these neurons are coming in towards the trigeminal ganglion, and the trigeminal ganglion is located in an area which I love called Meckel's cave. So it's located in this area called Meckel's cave. And Meckel's cave is located in the middle cranial fossa. Now, remember this. These neurons are coming in. They're going to have their cell bodies here, right? Remember, they've got information about touch, proprioception, nociception, and temperature, and they're coming in. Now, as you can see with these various cell bodies, we call these neurons pseudo-unipolar neurons. Now, what that means is that the axon branches in two. So it's not that one is an axon, the other's a dendrite, it's actually the axon branches in two. Now, the reason why this is important clinically is the fact that, again, think about that ophthalmic division. I told you innervating aspects of the dura mater and the vascular supply, the trigeminal vascular system is what it's called. Because there's axons going both directions, information isn't just being sent in this direction. Things can actually theoretically be sent down the axons in this direction. And there's a thought that maybe in cases of headaches and migraines, certain peptides are being sent down here through that ophthalmic division, again, maybe exacerbating that of headaches and migraines. So we've got these cell bodies, we've got these neurons, they're coming through now. Importantly, those neurons associated with proprioception, their cell bodies are not located in the trigeminal ganglion. We'll talk about that in a second. So these neurons come in, they go through the trigeminal root, which is that there, and it enters finally the central nervous system, specifically the brainstem, specifically that of the level of the pons. So we've got the midbrain, the pons, and the medulla. So it's entering at the level of the pons. Now, these neurons have a decision where they need to go. There's a couple of nuclei in the brainstem associated with that of the trigeminal nerve. Now remember, nuclei, this is where cell bodies sit inside the central nervous system. So these fibers, they can decide to go up, across, or down, depending on the type of information they're sending. So importantly, those associated with proprioception, they ascend up towards the midbrain and they go to this set of nuclei here. This is called the mesencephalic nuclei of the trigeminal nerve. The mesencephalic nuclei of the trigeminal nerve. Let's write that down. So we've got the mesencephalic nuclei of the trigeminal nerve here. This is where proprioception goes. So maybe we can write mesencephalic nuclei next to proprioception here. Now, information that's been said about touch, generally speaking, will go to this group of nuclei here, called the principal sensory nuclei. Let's write that down. And because this is associated with touch, we can write it down here. And then information about nociception and temperature, that's going to move down here to this group of nuclei called the spinal nuclei of the trigeminal. So let's label that spinal nuclei. And we can put it here as well. All right. So we've got information about proprioception going to the mesencephalic nuclei, information about touch to the principal sensory nuclei, and information about nociception and temperature to the spinal nuclei. Now what happens? Well, before we move on there, I want to talk about that of motor output. We've got nuclei here. So here are the three nuclei associated with the sensory divisions of the trigeminal nerve. Here's the motor nuclei. So it's going to contain the motor neuron, and it's going to send it out through that trigeminal trunk, and it actually moves through with V3. And what's it going to innervate? It's going to innervate muscles associated with chewing, so allowing for us to chew, close our jaw. Think of the masseter muscle and the associated muscles as well. So that's very important. So that's the motor output. That's why it's a mixed nerve. 3 sensory divisions, 1 motor division, predominantly. All right, importantly here with the spinal nuclei, it's not just nociception and temperature entering it from the 5th cranial nerve, the trigeminal nerve. You actually have nociception and temperature-based information, predominantly, being sent to it also from other cranial nerves. What are these cranial nerves? It includes cranial nerve 7, cranial nerve 9, and cranial nerve 10. Do you remember those cranial nerves? That's going to be the facial nerve. Cranial nerve 9 is going to be glossopharyngeal. And cranial nerve 10 is going to be the vagus. So they send sensory information as well to the spinal nuclei. Brilliant. All right, so what now happens? Now remember I said that the cell bodies of proprioception aren't actually located here in the trigeminal ganglion. They're actually located here at the mesencephalic nuclei of the trigeminal. Now this is the only time you're going to see the first order sensory neuron have its cell body located inside the central nervous system, which is interesting. Why is this the case? I don't know. And it can synapse out here. All right, now what does the mesencephalic nuclei do? It's carrying proprioception. What does proprioception have to do with that of the face, head, neck, associated areas? Well, think about this, chewing. What stops us from biting down so hard that we break a tooth? Proprioception. We know how contracted and relaxed the jaw is. So a proprioceptive piece of information can be coming in from the jaw, moving through, going to the mesencephalic nuclei, and it can actually send this neuron straight back down to the motor nuclei and synapse with it for a reflex arc, mitigating or altering how forceful a jaw contraction can be. So this is the jaw reflex arc that's happening, right? From the mesencephalic nuclei, a proprioceptive base signal is being sent down to the motor nuclei, and that's going out to the muscles of the jaw. Brilliant. Okay, what about the other pieces of information? Well, they coalesce and they can come together to form the trigeminal tract. And so they're synapsing with their second order neuron. So there's second order neurons here at the nuclei. That's why they're called nuclei, because this is where cell bodies are. It's the cell bodies of the second order neuron. So they're located here and they're going to come together. Even those of the proprioceptive. They're going to come together, they're going to decussate and cross to the other side, around about the level of the midbrain. And then it's going to move up to that of the thalamus. So here we have the thalami, one either side. So I'm just going to label the one on this side to make it easier. And so it moves to the thalamus, where it's going to synapse with the third order neuron. So as you can see, sensation, sensory information, is a 3 neuron chain. We've got the first order neuron going in, synapsing with the nuclei in the brainstem, second order neuron moving through, decussating across it around about the level of the midbrain, ascending up to the thalamus, synapsing with the third order neuron. Now this is important. The thalamus is the relay center of the brain. It takes sensory information and decides where it needs to go. If we need to become consciously aware, it must move through the thalamus. The thalamus sends it to areas of the brain associated with conscious awareness, which includes that of the cortex, right? The cortex. I'll write it up here actually. Cortex. So it takes this third order neuron and sends it off to the cortex. Now, we're focusing on the somatosensory cortex, located in the parietal lobe. Let's write that down. What we've got here is the somatosensory cortex, located inside the parietal lobe, or located at the parietal lobe. And remember, the somatosensory cortex has a map of the entire body regarding sensory information. A whole map of the body. Areas that have more dense locations of neurons are going to have larger areas mapped to it. That includes that of the face. And in actual fact, the face is predominantly located in this particular area here. So we're going to have things like the eyes, we're going to have the nose, we're going to have the lips and the tongue and so forth. So this information is going to be sent to this particular area via the thalamus. And here's our 3-neuron chain. Now I told you we're going to be talking about pain, right? So all I've spoken about is sensation. We've now become consciously aware that something has happened to some aspect of our face. But what happens if you've got a pain in your tooth? All right, let's think about it. You have some sort of noxious stimuli that's triggering nociception. So you've got nociceptive neurons, nociceptors, picking up noxious stimuli, which may be actual or potential tissue damage. It's going to send a signal, just like we've done here, into the trigeminal ganglion, from the trigeminal ganglion down to that of the spinal nuclei, because I said that's where nociception enters, synapses with the second order neuron that goes up and across, and then synapses at the thalamus, and then goes to the somatosensory cortex. And we know that some area of our mouth or tooth or wherever it may be is experiencing some sort of noxious stimuli. But we're still not experiencing pain. Nociception and pain are a little bit different. Nociception is simply picking up noxious stimuli. Pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage. That's the International Association of Pain's definition of pain, right? So an unpleasant sensory or emotional experience associated with actual or potential tissue damage. All right, so how do we now experience pain from this piece of information? Well, this trigeminal tract that's taking this information up to the thalamus, it actually sends off different signals to talk to different aspects of the brain and brain stem for us to experience pain. So for example, what it does is it can send signals out to some really important areas. Which areas? Firstly, it can send signals out to this area here. You can see there's a long area of nuclei called the reticular formation. Now the reticular formation is important for sleep-wake cycles. Things like arousal, for example. And so if this sends signals off to the reticular formation, we become well aware that, oh, something's happening. I'm wide awake. What's going on? It also is the reason why it's hard to sleep when you're experiencing pain, because of signals being sent to the reticular formation. So now we've got that arousal associated with pain, right? What else is happening? Well, signals are being sent to that of the limbic system. This here is part of the limbic system, specifically the amygdala. And the amygdala allows for us to experience the emotional effect of pain. We now have some sort of emotional experience tied to this nociceptive signal. What else is happening? Well, it can send signals off to this area here underneath the thalamus, the hypothalamus. And we know if there's some sort of stressful stimuli, you can trigger the hypothalamus to release a whole cascade of hormones, including hormones that travel to the adrenal gland to release adrenaline and cortisol. And we can have that sympathetic effect, the fight or flight effect associated with pain. So it means increased heart rate, changes in breathing, sweating. So we can have that sympathetic change associated with pain because of triggering that of the hypothalamus as well. All right, so now what we've got is we're wide awake, we are aroused from that pain, oh, something's happening. We now have some sort of negative emotional experience associated with that pain. We've also got a sympathetic response associated with that pain, and we also know where this painful stimulus is or has arisen from because it's gone to the cortex. But a couple of other things happen. So here's something really important. When you are stressed, what do you tend to do? What do you tend to do with your jaw? You tend to tense it, right? Your jaw tends to be tense when you're stressed, and people get that pain associated with their jaw as well. Why is this the case? Well, we don't fully know, but there is a theory out there that one part of the reticular formation located up here, called the locus coeruleus, And the locus coeruleus sounds like my favorite Roman emperor. The locus coeruleus is actually the side of the brain associated with noradrenergic neurons, noradrenaline, right? Now here's the thing, you're stressed, right? Oh, I've got a deadline due for an assignment or whatever it may be. It triggers the locus coeruleus. The locus coeruleus will send noradrenergic neurons to the motor nuclei of the trigeminal. And what it does is it releases noradrenaline. Now the thing is, when noradrenaline meets a motor neuron, it tends to excite it. And if you're exciting a motor neuron associated with jaw contraction, you're going to have stronger jaw contraction. So there's a theory out there that because of stimulation from stress of the locus coeruleus, it's sending noradrenergic neurons, releasing noradrenaline to the motor neuron of the trigeminal nerve, and that jaw contracts. But importantly, our body tries to mitigate this pain endogenously. So without us accessing certain medications like non-steroidal anti-inflammatory drugs, accessing things like opioids or even local anesthetics if needed, the body tries to release its own pain relief chemicals, including the opioids. Now, these are things like endorphins, enkephalins, and dynorphins. How does this work? Well, first thing that happens is when all this is triggered, this trigeminal system that's moving up, and you can see you've got all those branches coming off like I spoke about before, it can actually send signals to this area here called the periaqueductal grey matter. So you can see here, we've got the lateral ventricles, you've got the third ventricle, the aqueduct between the third and fourth ventricle here, and then the fourth ventricle here. So either side of this aqueduct, we've got the so adjacent to, near, aqueductal grey matter, because it's a whole bunch of cell bodies. Remember, grey matter is cell bodies. So we call it the PAG. Now the PAG is really important in this endogenous opioid system, this descending inhibition of nociceptive stimuli. And what it does is it sends a signal from the PAG down to this area here called the Raphe nuclei. And the Raphe nuclei has serotonergic neurons associated with it. So it sends a serotonin signal, serotonergic neuron down to the spinal nuclei, and here it synapses with an interneuron, which synapses with the secondary neuron. Let's just zoom in on it a little bit. Let's draw it up here, right? You got the serotonergic neuron coming in, releasing serotonin, right? That's serotonin. And it releases it to an interneuron, and this interneuron will synapse with that secondary neuron that's supposed to go up towards the thalamus. Okay? And it's sending a nociceptive stimuli. But we don't want a nociceptive stimuli. We don't want to experience pain. So the serotonergic neuron releases serotonin, which stimulates this interneuron here, and the interneuron releases the opioids, the endogenous opioids, right in this space here. Now this includes endorphins, dynorphins, enkephalins. And they help inhibit that signal. So it's inhibiting a painful stimulus. Brilliant. Now the other thing that can happen is that the locus coeruleus can also send a noradrenergic neuron down. Now I know it's getting a little bit messy here, but it sends this noradrenergic neuron down. Now I'm not going by the right tracks here. This is just a schematic so that we understand the concept. And it also releases noradrenaline at this site. Now, specifically, when you've got a noradrenergic neuron coming in, I'll put it here, releasing noradrenaline. When noradrenaline comes across a sensory neuron, it will bind to alpha-2 receptors. Now, what does that mean? Alpha-2 receptors. I know we're getting busy here, but let's take a look. Remember when we look at adrenergic neurons and adrenergic receptors. So when you throw adrenaline at certain receptors, what does it do? Well, it's there predominantly to stimulate a fight or flight response, right? Now there's different adrenergic neurons. You've got alpha-1, beta-1, alpha-2, and beta-2, right? Now if you throw noradrenaline at these two, you stimulate whatever tissue to do its job. If you throw noradrenaline at these two, you inhibit the tissue from doing its job. So think about it. I have a sympathetic response. I want my heart rate to increase. Therefore, I'm going to throw noradrenaline at my heart. I want to stimulate the heart to do its job. So it's going to have one of these two receptors on it. It actually has beta 1. But my airways, if I throw noradrenaline at my airways, I don't want to stimulate the muscles of my airways because that will tell them to constrict and narrow. But I want more air in there. So I need to inhibit the smooth muscle from contracting. So it's going to be one of these two. And in actual fact, it's beta 2. Now, if I want to inhibit a neuron from sending a signal, it's alpha 2. So down here, these neurons, or this particular neuron here, the secondary neuron at the spinal nuclei is going to have alpha 2 receptors, and it's going to inhibit it from sending that signal. Again, mitigating the pain signal from being sent. So I know it's a little bit busy, but this is how painful or nociceptive stimuli get sent through for us to experience a painful situation, and also how the body tries to mitigate that pain endogenously. Now, a lot of the time this doesn't necessarily work, and we need to access pharmacological interventions. Things like NSAIDs, non-steroidal anti-inflammatory drugs, opioids, and even, if you go to the dentist's, local anesthetic. So that's the trigeminal nerve and its involvement in orofacial pain. Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMiketodorovic. Speak to you soon.